This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Shuvro Roy from the University of Washington, and welcome to today's Neurology podcast. I have the pleasure to interview Annette Langer-Gould, Regional Lead for Translational Neuroscience in the Southern California Kaiser Permanente system. Annette and I are going to discuss her article in N2 titled Multiple Sclerosis, Rituximab, Hypogammaglobulinemia, and Risk of Infections. Dr. Langer-Gould has helped provide answers at a population level on a number of topics in MS that have really helped reshape our view of the disease, from clarifying incidence in different racial groups, management during pregnancy and the postpartum period, disparities in care, predictors of disability, and much more. Annette, I don't have to tell you this, the use of B-cell depletion, often with ocrelizumab since its arrival in 2017, but in reality even earlier with the use of off-label rituximab, has provided tremendous advantages in MS care. The B-cell depleters offer dramatic control of acute inflammatory disease activity, significantly reducing risk of progression into disability down the road, and providing long-lasting coverage for situations like in the pursuit of pregnancy, as we discussed with Riley Beauvais in a recent episode. As such, they're becoming one of the most heavily utilized medications in MS management, but with that comes the risk of placing someone on long-term immunosuppression for years, perhaps decades at a time if one is newly diagnosed. Annette, thank you so much for joining us.
You're welcome. I'm really excited to talk about this today. This is a topic that's near and dear to my heart. And most people know that we've been using an awful lot of rituximab in the Kaiser system since those randomized controlled trial results were first released in 2008. That's a full decade before ocrelizumab was even available.
Well, it's certainly something that's important to me too. I couldn't agree more. And could you take us through what inspired you and your colleagues to delve deeper into the infectious risks of B-cell depletion?
Yeah, it was really our patients. They were asking us if rituximab could become their forever treatment. So we figured out really early on that this is a great drug for relapsing remitting MS. It's really like a magic bullet for that disease. But when we first started using it, we were using the doses in the original trials, which was 1,000 times 2 every 6 months, quickly went down to 1,000 every 6 months. Over time, they were getting infections and they were getting low immunoglobulin counts, which we all know increases risk of infection. So it was really to try and understand for them, if we want to make it forever treatment, then we need to know a lot more about who's at risk for infection and what can we do to reduce that risk of infection. So really looking for modifiable factors.
And generally, when we manage these patients, we're keeping track of certain labs, whether it's serum immunoglobulins, some folks even dose based off of CD19 counts. But you're right, it's a little bit unclear as to who exactly is going to develop those infections over time and really what we can do to modify that risk. And that's what I really appreciate about this study, because there's a lot I learned just in terms of who we should be targeting or who we should be concerned about. So can you take us through the design of the studies and what questions were you hoping to answer?
We had started using these lower doses of rituximab because we learned really early on that the doses were too high and we were getting more infections, but not getting better disease control. And that's actually work that Jonathan Salzer published in Neurology around that same time. And we really wanted to know whether what we were doing was right. Were we able to reduce the risk of infection and prevent hypogammaglobulinemia? And how important was that in reducing the risk of infection? And then identify who really is at risk and what are those modifiable factors. So to answer those questions, we looked through the electronic health records, both manually and electronically, of the 2,500 patients or so that we had treated between 2008 and 2020 with rituximab. We wanted to look specifically at serious infections. We defined it a little bit differently than it's been done in other studies. We included pseudorelapses because they're really important to patients. So if they're hospitalized for infection, even if it's a pseudorelapse, we included that. So we defined it the way they do traditionally in clinical trials, which is requires hospitalization or worse, or prolonged an existing hospitalization. And then based on our patient feedback, we also wanted to look at recurrent outpatient infections. So seeking care for a single outpatient infection actually turns out to be super common. Most patients in Kaiser, particularly age and sex-matched controls to these patients, were seeking care twice a year for infections. So we define it as 3 or more infections that they were seeking care for in the outpatient setting over any 12-month period, and looked at those separately from the serious infections.
So to summarize, you looked at the cumulative rituximab dose over time and the correlation with those infections requiring hospitalization, pseudorelapses as well, recurrent infections, and then the lower serum immunoglobulin levels. Is that right?
Yeah. So again, we included pseudorelapses in the definition if they required hospitalization for their increased stability in the definition of serious infection.
And what were your big findings?
Our big picture findings are that if you have received higher cumulative doses, so it's about the total dose, not the total amount of time, and you also got low IgG from too much rituximab, it's a double whammy. You're like at doubly high risk of getting serious infections and recurrent outpatient infections. But luckily, that was actually rare because of the way that we've been monitoring immunoglobulin levels and pulling back, extending dosing intervals and reducing doses if we noticed that somebody's levels were trending down. So we didn't do that initially, which is why we still have some of those patients in the study, but we had started doing that pretty routinely by 2017-18. So our other big finding was that the number one risk factor for serious infection, so being hospitalized for infection, was advanced disability from their multiple sclerosis. And we had defined that as a walker, wheelchair, or worse. If you take that together with a lack of efficacy in people with a really advanced disability, remember those were all excluded from the trials, and the very minimal efficacy in people who required walkers, it looks like B-cell depleting therapy is probably risk without benefit in those patients. And then lastly, the other big takeaway is that we really need to incorporate comorbidity prevention and treatment into our routine MS practice, because it's not just B-cell depleting therapies. We have a lot of other therapies that increase the risk of infection in multiple sclerosis. So we really need to take that to heart and make that part of our routine questions and counseling for our patients.
Yeah, and that's absolutely my number one takeaway as well. Just even earlier this week, we were having this discussion of when do we space patients out? When do we adjust their dosing? And there are certainly some patients who you see hypogammaglobulinemia. And yet when I see them in clinic and ask, oh, hey, are you having any new infections, any new infectious symptoms? And they'll say, no, not at all. I feel great. But lo and behold, those are the patients that have, say, like an EDSS of 1 or 0, and they're doing great. But this certainly passes the smell test that, okay, if you are more disabled, you are certainly more medically frail, more likely to develop those infections. And now it's helpful to know that this is what we're seeing in larger data as well. You mentioned the taking into account modifiable and say non-modifiable risk factors. What were those other modifiable and non-modifiable risk factors you identified besides the rituximab dose, the hypogammaglobulinemia, as well as moderate to severe disability?
The main modifiable factors were COPD and obesity. Both of those independently increase the risk of recurrent outpatient infections. And then diabetes, interestingly enough, increases the risk of hypogammaglobulinemia. I don't think anyone's ever looked at that in any of the MS populations before. So it is indirectly contributing to their increased risk of infections. In terms of non-modifiable factors, age, of course, was a big one. We know in older patients, their immunoglobulin levels drop. It's also a risk factor for these infections. And then we had shown in a previous study overall comorbidity burden, so using a comorbidity index when we looked across all treatments. And those were sort of our big non-modifiable factors. For gender, it's kind of interesting. Women are much higher risk of recurrent outpatient infections because it's UTIs that are sort of the number one MS-related recurrent infection. That's rare in men, but they seem to be a little bit lower risk of serious infections.
Interesting. And one other thing I was curious about, you also did sensitivity analyses modeling on the decline in IgG values in the normal range and associated risk of infections, which I don't think I've seen in the literature to date. What did you find there?
Yeah, so we found that the thresholds we used, 700, 500, those were the right thresholds. If their values are dropping, but they're still in the normal range, it doesn't increase the risk of infection. So that's very reassuring. And that's consistent with what immunologists know about patients with acquired or genetic forms of hypogammaglobulinemia.
Oh, that is helpful. In terms of any patterns and how patients were dosed over time, did you find any particular patterns that you noticed as patients were receiving their rituximab over the years? And if so, what were they?
We had developed a protocol sort of by consensus in Southern California with the other MS specialists back in 2017, and even a little bit earlier in conjunction with the Swedish MS registrar group through a funded grant. And we saw that that was actually being followed in most patients. And so over time, we start patients typically 1,000 in the induction dose and then 500 every 6 months for the next couple of years, 2 to 3 years. If they're stable, they go down to every 12 months, so once a year. And then if they're stable on that for a couple of years, they go down to every 18 or 24 months. And then usually we park them there. Until their immunoglobulin levels are too low, they don't want to take it anymore, or they've turned 60, 65 and been stable for a long time.
And you mentioned earlier, a lot of folks are not using rituximab. The FDA-approved B-cell depleting drugs for MS are, of course, ocrelizumab and ublituximab. How do you feel like these results generalize to those two medications? I know we just had the 10-year safety data released on ocrelizumab, also looking at rates of serious infections with that medication.
The principles behind B-cell depletion that are the same with all three of these drugs, and that there is something called sort of a minimally effective dose that hasn't really been identified with any of these drugs, but we're certainly much closer with rituximab than we are with ocrelizumab or ublituximab. And I think the take-home message, use the B-cell depleting therapies and don't give them too much. That's how you're going to reduce the risk of infection, and monitor the immunoglobulins. If you see those counts dropping and hovering around 700, they started off 1,000, now they're 720, and they're due for their next 6-month infusion, maybe you don't want to give it to them because with each infusion, you're going to drop their counts again. It's also really interesting to me that the ocrelizumab infection rates are really high. And they presented the data out of their observational study, their phase 4 open label study, looking at only newly diagnosed patients with EDSSs of less than 3. So that's a normal to near normal neurological exam. So really pretty minimal findings on exam. And we're showing a 2% per year serious infection rate, so hospitalization for infections in young, healthy, newly diagnosed patients with relapsing remitting MS. And that is a lot lower than what we found in this study, even though we looked at patients, whether they were newly diagnosed or not newly diagnosed, that had just cane or less. So our patients are sicker, more diverse, have lots more comorbidities, had more disability, and we are only getting about a 0.8% per year risk of hospitalization for an infection in patients with cane or a lower level of disability. So that I think is pretty telling evidence that the doses are way too high for ocrelizumab.
The major takeaway for me, there's the mechanism, the increased risk of infection was not necessarily primarily driven by hypogammaglobulinemia. And you just mentioned a clinical pearl on monitoring these immunoglobulin levels, but especially for folks who may not necessarily be MS providers, but certainly care for patients with MS and have patients on these medications. Based on the information of this study, are there patients you would not recommend treating with B-cell depletion?
Yes. So certainly, in our practice, patients with advanced disability of inactive MS, this is risk without benefit. So if they're already in a wheelchair, particularly if they're older and they haven't had an active lesion or a bona fide relapse, so not a pseudo relapse, but a bona fide relapse in the last 3 to 5 years, we don't give them these drugs, or we try not to. And then I would say in other rare circumstances, if they have active cancers, we suspend treatment. So if they're already getting chemotherapy or getting other immunosuppressants, this is not their biggest health problem. And we don't want to compound the risk of infection in those patients either. Yeah, and then we'd use very limited protocols. So people with radiologically isolated syndrome, we will just treat for 1 year and that 1 or 2 years max. And then we do treat upon return of disease activity. We monitor their MRI scans and their exams, MRI scans every year and their exams at least every 2 years. And we don't retreat unless their disease becomes active again.
That's interesting. That leads into the discussion of what you were just talking about, of altering the dosing patients. And so, in my practice, I often transition patients to extended interval dosing after a few years on drug to minimize that overall risk, which I can't take credit. I learned that from one of my mentors, Ellen Mowry. But I'm not necessarily using specific biomarkers or even demographics, at least not until now, to guide that decision. But just again, to summarize, based on your study findings, what recommendations would you offer to clinicians regarding the use of rituximab and the other B-cell depleters, especially when it comes to adjusting the dose in patients with MS?
You're trying to match up the benefit of the drug. So you want to know what kind of MS they have. Do they have active disease or inactive disease? So have they had a relapse or an unequivocally new MS lesion on their MRI scan in the last couple of years? So those patients are very likely to benefit from treatment, whereas your inactive patients are not that likely to benefit. So you may pull back on the drug sooner. And then also age, because younger patients we know have more active disease. So probably suspending treatment altogether in somebody who's in their 20s, eventually the disease will come back. We do this standard de-escalation where if they're young and healthy and they're tolerating the drug just fine and they've been stable on 500 milligrams every 6 months after that initial 1,000 milligram dose for a total of 4 infusions, so that's roughly 2 years of treatment, we'll go down to once a year infusions in those patients. If their immunoglobulins drop before that, we will pull back. If they have progressive MS and they're continuing to decline at the same rate, we will stop typically after 1 or 2 years. And usually the patients want to, because we'll tell them the number one problem with this drug is that it probably won't work for you. That's your number one risk on this therapy. We'll try it 2 infusions 6 months apart. And if in a year you don't feel like it's making any difference, then we'll just stop it. And so we'll use those key elements for deciding when to pull back. And then if they've been stable for several years on once a year, then we'll go down to 18 to 24 months, depending on how they're feeling. And of course, in pregnant patients, we sort of pioneered the use of this drug in pregnant patients. And those patients, we just don't dose them. And we don't push them to resume fast during postpartum period either, because it doesn't look like they need it. They're sailing through easily 1 year postpartum, even if their last infusion was roughly 2 years ago without postpartum relapses or new lesions on MRI. So in those patients, we'll check their MRI scan after they've given birth, not immediately, but when they can get there. So typically around 3 months. And if their MRI scans are stable, then we talk about like maybe restarting the therapy 9 to 12 months postpartum.
You summarized it beautifully. I mean, in terms of really what we're trying to do with these treatments, we're trying to hit that sweet spot of reducing active inflammatory activity, especially in those years where MS is most active, according to that topographical model by Stephen Krieger, can lead into that disability down the line. But we also want to reduce, or at least provide the lowest effective dosing regimen of these medications. And you've mentioned really, obviously, we've talked about extended interval dosing in a couple different ways here. At the very beginning, you mentioned starting folks at 1,000 milligrams, then reducing the dose from there. In terms of reducing the actual received dose, whether it's rituximab, ocrelizumab, or ublituximab, do you have any guidance on that?
Well, so we give that just that initial dose of 1,000 now, and then 500 every 6 months thereafter. And then we go down to 500 once a year, 500 every 18 to 24 months. That's our typical regimen. We also use B-cell counts if their immunoglobulins are dropping or they've had infections. So I think that would be the other group that I wouldn't treat. If they've already been hospitalized for serious infections, this is probably not a good drug. Those patients typically have other severe comorbidities that could either be controlled or they have advanced disability or both. So it's also usually a group that doesn't benefit from it. The other thing that we will do is in patients with dropping immunoglobulins or who've had a couple infections but have responded really well, we'll use their B cell count when to retreat. So if they still don't have at least 40 B cells and they're coming up for their annual infusion, we're like, what's the point? We're not going to do this. We know we're going to increase your risk of infection. And you are now immediately going down to every 2-year infusions. In some patients, it takes a really long time for their B cells to come back. We have one patient who hasn't had a dose in something like 8 years and has no B cells back. So, yeah, wow. I think it's rare, but you'd be surprised if they've been on it for several years at standard dosing. It takes them much longer to replete their B cells than we see in sort of those initial dose finding studies for rituximab, but also I think ocrelizumab, and it's going to be the same with the other B cell depleting therapies. So it's not a bad idea, even if you're moving to once a year dosing, to start looking at those CD19 counts and seeing whether you really, really need to retreat in somebody who's looking like they're at risk of infections.
That's valuable, especially knowing there have been a few studies, even with extended interval dosing, that even repopulation of the B cells that may not even necessarily be tied to disease activity, even meaning that even as patients repopulate, they're not necessarily having new MRI lesions or clinical attacks. So this is just a huge step forward in terms of our understanding of the treatment of patients with the B cell depleters, as well as better understanding their infectious risk over time and thus giving us better context on how to manage these patients. I'm just curious, from your perspective, are there any specific areas where there's additional research that you think is needed, especially understanding the mechanisms between infectious risks associated with rituximab in these folks with MS? And what would you like to see investigated from here?
Yes. Well, the burning question for us is who we do see a small number of patients relapsing on rituximab. It looks like it's about the same, whether they're on every 6 months, once a year, once every 2 years, or even more than once every 2-year dosing. And we're trying to understand who those patients are. So stay tuned. We'll be presenting that data at the American Academy of Neurology on Wednesday afternoon. And we'll be showing some of the B cell data. Obviously, people who are on every 2-year infusions, they've got B cells back, in large numbers, and most of them are not relapsing. And then I think that the other big burning question is, are we using this drug right at all? Ellen Mowry had asked me when, I told her that we're parking them at every 2 years until they're 50, 55, until those discontinuation trials come to fruition. Certainly by 60, you can just, assuming they've had stable disease for 10 years before then. I'm not talking about people whose first MS relapse was 52, that you can stop them at 60. But say we started them on it when they were in their 30s. What I really want to know, and Ellen asked me, is do you think it's doing anything when you're giving them 500 milligrams every 2 years? And I really don't know. I wonder, should we be using this treatment the way we use alemtuzumab and cladribine? Should we be giving them a few years of therapy, resetting their immune system, and then treating upon return of disease activity? So I'm hoping that when we finish analyzing our data, we'll at least know who that small subgroup is where we probably should just continue therapy on those patients, give better guidance. But I think those are sort of my burning questions, is could we just, in a large number of patients, could we just stop the therapy and call it a day?
I guess I now have plans for where I'm going to be on Wednesday in Denver, and I'm really excited to see these results. Annette, thank you again so much for taking the time. Again, this is going to be coming out in N2 titled Multiple Sclerosis, Rituximab, Hypogammaglobulinemia, and Risk of Infections. Annette, thank you so much for joining us.
You're welcome. Thank you so much for having me.
That's been today's Neurology podcast. Thanks for tuning in.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.